Okay. Good morning, everyone, and welcome if you're just joining us. My name is Julie Labra from MND Australia, and together with Min from FightMND, we would like to welcome you to today's webinar, sharing the results of our 2025 National MND Community Survey. I'm joining from Gubbi Gubbi country in Queensland, but we would like to acknowledge the traditional owners of the many lands from which you are dialing in from, as well as any First Nations people participating today. And we pay our respects to Aboriginal elders, past, present, and emerging. We warmly acknowledge the lived experience community across Australia, including those who carry an MND-related gene, people currently living with MND, and the families, friends, and carers who support them. Through our work, we honour the strength and resilience of this community, and we remember with deep respect the thousands of Australians who have lost their lives to MND.
So last year, FightMND recognised the need to identify the priorities of people impacted by MND across Australia, particularly from a care and research perspective. So we reached out to MND Australia and partnered with them to develop a national community survey. Given the large scale of the project, we utilised external consultants, Acil Allen, to coordinate the development, analysis and reporting of the survey results. And Lockie, Amy and Charlie from the Acil Allen team were instrumental in coordinating this project, and we extend our thanks for their dedication and their leadership. So on today's agenda, Amy and Lockie will present a summary of the survey results for around 30 minutes, after which Claire from MND Australia, Kate, who will be representing the state MND associations, and myself from FightMND will each take a few minutes to explain how the survey results might shape our future work. In the last 15 minutes, we'll also have some time for Q&A. So if you do want to ask a question, there's a little question and answer box at the bottom of your screen, which you can click on and type your questions in. So feel free to enter your questions there. And Julie and Laura from MND Australia will monitor the questions and ask them to the panelists at the end of the session. So with no further ado, I'll throw the presentation over to Amy and Lockie.
Thanks, Min, and thanks everyone for joining us today for this webinar. My name's Amy Merton and I'm the Executive Director of Acil Allen's Melbourne office. For those of you who aren't familiar with us, we're an independent policy, economics and strategy advisory firm who does quite a lot of work with the not-for-profit sector, in the health sector with researchers and also with government more broadly. Before we get too far in, I'd just like to also acknowledge the traditional owners of the lands in which I'm dialing in from today. So that's the Wurundjeri Woiwurrung people of the Kulin Nation, and pay my respects to elders past, present and emerging. I'm going to talk through briefly this morning a little bit about the research method, so the objectives, the design, the way in which we distributed it, and the ultimate sample size that we're working here. And then I'll hand over to Lockie from our team who'll take you through the findings. So in terms of the purpose of the research, as Min and Julie mentioned, this research was jointly commissioned by MND Australia and FightMND. And the purpose of the research is to provide an opportunity for the community to actually share their voices and their perspectives on their experiences of living with and being impacted by MND, their priority needs in terms of supports and assistance, and also the areas in which they would like to see greater research and policy advocacy undertaken. It's a really important tool in being able to help ensure that the work of MND Australia and FightMND is guided by the community, and that connectivity is really clear in terms of where efforts are focused. We recognise the importance of including community in the design of this research project, as well as the analysis of the findings, and ultimately coming to you today to share the results of this webinar. And so we went through a co-design process with a very large range of people who I will personally thank in a moment, including workshops with people living with MND, carers, gene carriers, clinicians and care researchers, state MND associations, FightMND and MND Australia. And so each of those groups was involved in helping us to identify the domains that we should explore through the survey, the questions in which we would ask and how best to ask those, and also the way in which we would capture information on demographics as we went through. The survey itself was distributed by MNDA, FightMND, and the state associations through a variety of mechanisms. And so I'd just like to thank them as well for their involvement in helping us get this survey out to community, and also to help us with promoting it to get the responses that we did. In terms of the analysis phase, we did a lot of the analysis independently ourselves in recognising our role within this particular research project, but we also held sessions with those same people that were involved in the design phase to help ensure that we were interpreting the results appropriately, identifying factors that may have impacted on the nature of the responses that we received, and contextualising those themes in the broader experiences of the community of people affected by MNDA. And those sessions are really essential in coming up with the findings that we'll talk through today. So if we'd like to move on to the next component, we'd just like to say a very particular thank you to those that were involved in the design of the survey. We recognise very strongly that that involved the contribution of not just time, but personal experiences, which can be quite emotional in many instances and required a lot of reflection from both community members, but the clinicians and care researchers that we were working with as well. So I won't read out all the names on this slide because we'd be here for most of the hour, but just wanted to acknowledge that all of the people listed here were really essential in getting this research up and running, and for us to be here today to speak to you about the results. And so just like to pay my personal thanks to everyone that has participated. In terms of the survey responses, I have to say we got a really great data set to be able to work with. There is a robust sample that was collected in terms of coverage of the community. So we had 495 total respondents, which reflected 227 people living with MND, 133 current or recent carers, 123 former carriers, and 29 gene carriers. If you're any good at maths, you'll see that those numbers don't add up exactly to 495 because people may fall into different categories as well, and that's important for us to note. The responses in terms of coverage of the country to allow us to provide a national snapshot did correlate with population. And so we had a good spread of responses from major cities, inner regional areas, and outer regional and remote areas as well. Just noting that in some instances, those sample sizes became quite small, so we weren't able to disaggregate the results in all the ways that we wanted. Probably the largest limitation in the sample that we would like to be clear about is in relation to cultural and linguistic communities. The total responses of people that identified from being from culturally and linguistically diverse communities was less than 5% of the responses. And we do recognise that that may have an impact on the results that we present here, particularly around accessing health services and supports and information. And we just wanted to be transparent about that. But in terms of other points, gender, we had a relatively even split in the responses, and we did have a spread of the different types of MND across people's individual experiences, recognising that there was also diversity in age, so most of our respondents being 55 to 85, and approximately half supported by NDIS, which is quite important when we think about those differences between NDIS, aged care, and self-funded experiences, which will come through the results as we speak today. So that's probably enough from me on the context. I'll now hand over to my colleague Lockie, who will take us through the detailed findings of the survey.
Thanks, Amy. The following slides will summarise the key findings of the survey. To start, we'll go with equipment and home modifications. This part of the survey asked people living with MND whether they had the equipment or home modifications that they needed, and what their issues were. This is important to people living with MND as equipment and home modifications underpin their quality of life, supporting their ability to maintain connections to family and friends, do things they enjoy, and connect to their community. As well, this is important for the quality of life for carers, who often have to work to overcome many of these barriers and advocate for their loved one. The survey found that half of respondents living with MND do not have all the equipment and home modifications they need. This means they don't have all they require to support their mobility, personal care, communication, or personal affairs. Some had very little or no access at all. Access to home modifications was reported to be more challenging than access to equipment. Key drivers for this included delays in approval and delivery for 50%, struggles understanding options for 41%, prohibitive costs for 39%, struggles with process of acquisition for 35%, and a lack of qualified tradespeople for 34%. Delays impact the quality of life for people living with MND as well as their carers. They can also reduce the effectiveness of equipment and home modifications, as they can no longer be suitable by the time that they are required. Understanding the options and the acquisition process was reported to be burdensome and overwhelming for people, particularly as the disease progresses and care needs increase. People living with MND emphasize the importance of government staff having adequate knowledge and understanding of MND. The new NDIS priority eligibility decision pathway for those living with MND under 65 years of age was intended to assist with this by fast-tracking the commencement of NDIS support. Though there were few respondents from this pathway, almost half of them still reported delays. This may indicate that the new NDIS pathway's focus on commencement doesn't address equipment and home modification delays on an ongoing basis throughout the process. Costs were also a significant barrier for many, with a sizable portion having to use their personal savings or free hire services. People with MND reported that the costs for equipment and modifications were both high, and some citing that equipment was often more expensive as a result of being associated with MND or the NDIS. Finding suitable tradespeople in the local area can also be difficult. And even when found, there can be further delays given workforce shortages. Some groups experienced these barriers more severely. These included people living with quickly progressing symptoms, people newly diagnosed with MND, people living in outer regional or remote areas, people supported by My Aged Care, which also, this group also reported that they utilized free hire services and more of their personal savings. And anecdotally, renters also reported additional issues due to a lack of appropriate rentals and restrictions on home modifications. Some potential supports include simplified processes and streamlined approvals, improved funding or cost controls, or improved support in application and the acquisition process. On to health professionals and clinics. This part of the survey asked people living with MND concerning their access to health professionals, care, and MND clinics. People living with MND go through a journey of diagnosis and then require support from a range of health professionals to receive direct care, referrals, reports, and scripts for other supports. Access to medical professionals that are knowledgeable about MND, therefore, is fundamental to the quality of life for people living with MND. As well, again, this is important for the quality of life for carers, who often have to work to overcome many of these barriers and advocate for their loved one. Challenges included 47% struggle to find health professionals with MND experience. 42% experience lengthy wait times. 38% face long travel distances. 34% report high cost barriers. And 33% experience physical barriers. There was also low access for some professionals, with only 41% accessing psychology and counseling, 31% accessing palliative care, and 27% accessing social work. On knowledgeability, People living with MND reported that few professionals had adequate experience with the disease. This is particularly relevant for general practitioners, which all those with MND need to access. Those living with MND also noted in consultation a low level of knowledge in public hospitals and emergency departments. Allied health professionals accessed through MND clinics, we seem to be more knowledgeable of MND than those in the community. 3 state MND associations provide allied health services for their members: Queensland, Western Australia, and South Australia. The allied health provided through these state associations was reported to be highly knowledgeable. Barriers to access, such as wait times, travel distances, or physical barriers can have significant ramifications for care, support, and quality of life. Medical practitioners that do have relevant expertise are often also more expensive, increasing the cost burden for those living with MND and accessing appropriate and knowledgeable treatment and care. Both cost and knowledgeability were also related to government support. People receiving support from the NDIS access allied health professionals more often through private practice, and people on my aged care make more use of public hospitals. Access to psychology, counseling, and social work was also related to funding. Clinicians and state MND associations noted in consultations that it can be difficult to gain approvals to use government support to fund these services. Or often, there is no funding left for these services after more pressing physical or personal care needs are paid for. Though not all those living with MND need access palliative care, still less than half of those with extremely impactful symptoms had accessed it. People living in outer regional or remote areas experienced further barriers. These included less access to MND clinics, more significant travel distances, and a further lack of MND experience. Some potential supports include improving access to MND clinics, which reported very high satisfaction, knowledgeability, and improvement to quality of life. Another is improving MND education for health professionals, as well as improving funding and addressing health professional shortages, noting that these supports are especially needed for people living in regional areas. On to carers. This part of the survey asked carers about their quality of life, supports, equipment and home modifications, and the challenges that they experience. Being a carer involves taking responsibility for the well-being of the person living with MND, actively caring for them day to day and acting as their advocate within various support systems. They're important to the life of the person living with MND, but are often in need of support themselves, as they face many of their own challenges in addition to supporting their loved one with theirs. Less than half of carers consider their quality of life to be good, our survey found. This is lower than both those living with MND and gene carriers, reflecting the intensity of the caregiving role, compounded by limited support systems. Some key drivers for this include 75% do not access respite care, 68% receive limited support from family and friends with care, 57% consider their access to paid care insufficient, 57% do not have the equipment and home modifications they need, 42% consider their funding insufficient, and 23% spend all their time caring. Of those that accessed paid support, the number of hours provided was limited. Also, the quality of paid support is impacted by the limited knowledge of MND, reportedly leading to continued reliance on the carer. Some carers reported no emotional connections or support from family or friends, or peers within the MND community. Carers may be at additional risk of isolation or burnout, reinforcing the importance of emotional support from professionals and not-for-profit organizations, who often reported filling this gap. Carers who did access peer support reported it was essential for them, providing both emotional connection and support, as well as practical information. There may be a number of carers who would like to access peer support, but struggle to do so due to limited time and prioritizing the needs of the person living with MND. Without the equipment and home modifications they need, the carer often takes on additional effort, work, and risk as they compensate through taking on additional demands such as lifting. Most carers report having impacts on their income, which can be exacerbated by a lack of suitable equipment and support. This is also related to government support. Almost half of those without government support payment reported they had somewhat or significantly less financial support than they needed. And they were less likely to report they had all the equipment and home modifications they needed. Some groups experience these barriers more severely. Carers living in outer regional or remote areas with less access to care and less MND expertise. Carers without government support and new carers. Some potential supports include increased government funding for their loved one and for them, improved MND training for paid carers, improved access to regular and flexible respite services, improved awareness and access to peer support, and improved psychological support. Gene carriers. This part of the survey asked gene carriers about their experiences and their challenges. An MND gene carrier is an individual who carries a positive MND-related gene fault, but is asymptomatic. These mutations are inherited, meaning they are passed down from parent to child. Gene carriers were important to identify separately, as while they share some experiences with the rest of the MND community, they can also face their own distinct challenges. Also, this community is comparatively small and geographically dispersed, and so their voice can be missed without a clear focus on them. The survey found that gene carriers feel disconnected from the MND gene carrier community and struggle to get access to timely and adequate genetic counseling. Some specific challenges include 54% report no or only some connection to the MND gene carrier community. 54% reported that their provision of genetic counseling was less than adequate. And 50% reported that their access to genetic counseling was not timely. The lack of connection to the MND gene carrier community may be due to fewer known numbers of people in the community and the dispersed geographical location. Information concerning MND gene carrier communities can also be difficult to find. One respondent reported that they discovered an Australian gene carrier group via an international contact and only did so years into their journey. Access to genetic counseling varies across Australia and may be particularly difficult for families who are not linked to an MND clinic, or if the clinic does not have genetic counseling embedded in the service. Genetic counseling is generally not covered through government funding, often creating an additional financial burden. Knowledge of GPs regarding MND and their support of genetic testing can prove a significant barrier to support. Gene carriers reported experiencing resistance from some GPs in providing referrals, which creates both delays and stigma for the person seeking genetic testing. Many gene carriers seek referral to neurologists for screening and additional information. Access is impacted by the same wait lists that face those living with MND. Cost barriers to genetic counseling may be even higher for these specialists when factoring in ongoing review costs. Some potential supports here include increased access to trials, more regular screening with neurologists, improvements to peer support programs, platforms, and increased provision of genetic counselling, as well as increased awareness of peer support groups. Priorities and research improvements. So this part of the survey asked respondents about their experiences with research and their priorities for research and advocacy. Research is important for improving the treatment and care options for the MND community. Policy is also important for ensuring that policy and government support consider the needs of community to best support their quality of life. Research and advocacy are also core parts of MND Australia and FightMND's mission and of critical importance to the MND community. A core function of MND Australia and FightMND is to fund grants for MND research. Hence, it's important for these organizations that research is meaningful and important to the MND community. Also, as the national peak body for people impacted by MND in Australia, MND Australia plays a large role in advocating for funding and policy improvements at a federal government level. The survey found that the MND community wants more communication about research opportunities and outcomes. The top research priorities concern the cause of MND and clinical trials. And the top advocacy priorities are equitable funding and MND clinics. Regarding research communications, for research, 70% reported wanting more communication about and access to current research opportunities. 68% of research participants do not hear about outcomes. Most people living with MND and current or recent carers wanted to be involved in research. While the majority of those living with MND have received an offer to do so, only a minority of current or recent carers had the same, reflecting research priorities. Regarding research priorities, the research priorities for the MND community were in order: identifying the cause of MND for 75%, new clinical trials to slow progression, 74%, new therapies to improve quality of life for 58%, and making the process of diagnosis quicker and easier, 47%. Evidence to support improvements to healthcare, social, and policy change was ranked last. When discussing developing evidence to support policy change in consultation, the MND community noted that it was unclear how this translates to quality of life outcomes for people living with MND and carers. Clinicians noted that care research has historically had less focus than discovery or scientific research, and so fewer people will have been involved with this kind of research nor seen its outcomes. The importance of advocacy to improve funding, systems, and access was emphasized by those living with MND and their carers in consultations. Therefore, the importance of this kind of research should not be understated. Regarding advocacy priorities, the advocacy priorities were: 1, equitable access to disability funding, regardless of age at funding commencement at 70%, increasing funding for multidisciplinary MND clinics to 47%. People living with MND reported that prioritization of funding was consistent with their experience. Funding is critical to getting the support that facilitates quality of life. MND clinics, as mentioned earlier, were reported to have a very high level of satisfaction with care, reflecting a high knowledgeability in MND and resulting improvements to people's quality of life. In addition to these priorities, there were a set of other almost equally weighted priorities, including increased access to healthcare professionals with MND experience, increasing funding for not-for-profit organizations, reducing wait lists, improving systems and processes with the NDIS, and minimizing healthcare costs for people in regional, rural, and remote areas. This spread amongst these priorities reflects the diversity of settings, locations, and supports in the MND community and differs between these groups. Some differences included that carers prioritize funding for clinics and healthcare professionals more than those living with MND. This difference may indicate the additional burden the carers take on in advocating for care with these professionals. Gene carriers placed additional priority on genetic counselling and reducing wait lists. People living in regional areas placed additional priority on improving access to services, including wait lists, minimizing costs, and increasing access to healthcare professionals in their local community with MND experience. And people supported by My Aged Care prioritized equitable access to funding, while those on the NDIS did also do so. They placed more emphasis on wait lists. So that concludes the summary of the findings of the MND Community Survey. I believe it's on to Julie next. Thank you.
Thanks, Lockie, and to you, Amy, as well. And can I just say what a pleasure it has been for us to work with yourselves and the team at Acil Allen over the past 10 months. So thank you for all of the efforts that you've put in helping us with this project. I'm going to hand over to Claire Sullivan now, the CEO of MND Australia. Over to you, Claire.
Thanks, Julie, and thank you, Lockie. That was really interesting, and it's a really important piece of work for us. I'd also like to thank everyone who participated in the survey. Your time in giving us advice and your views is really important to us. It's remarkable what an engaged community we have. I think the survey data around quality of life is really heartening, but it shows that there's a lot more work for us to do. And that's exactly what we at MND Australia do, what we do in partnership with our state and territory associations, and of course what FightMND do. There's a few things that I wanted to talk about in terms of what's next. Now we've got this survey and a stronger evidence base. What do we do with this information, and what will we be doing? The first really obvious area is the importance of specialist care. People with MND need high quality healthcare providers. They need specialist allied health. They need equipment and home modifications. And they need this in a way that caters specifically to their needs and that is provided by people who understand the disease, understand the complexity of the disease, and the various different ways in which it manifests in various different people. So I think it's really important that we all recognise the importance of specialist MND care across the country. The other one is around quality of information. I was really heartened to see the importance and the value that people place on the information they get from state association newsletters and websites, and of course MND Connect, the information resources that are provided there. There's a recent piece of research that Karen Hutchinson's just published with Keith and Anthea, who are on the call, and it's around the importance of multidisciplinary care, specialist clinics, and community care, and that spectrum of care provided across the country. The report's titled, "Finally in Hands I Can Trust," and I think that really says it all. The community survey had a lot of information around research, and we hear you. Absolutely. The importance of making research accessible, ensuring that participation is easy and possible for people with MND, making sure that research is impactful and has that immediacy of outcomes embedded into it is what we've heard. For MND Australia, there are a range of things that we'll be working on to do and improve. There's a lot of regulatory frameworks and sort of government structures that impact on the way that research can be undertaken. Changing regulation is a long-term game, but definitely something we will be prioritising as part of our advocacy with the federal government. We, of course, have our own research program, and we'll be looking at how we can further include people with MND and carers, their friends and families, so that research is accessible, but also looking at the research that makes the biggest difference to you. the importance of care research, of action research, of applied research, of that sort of research that has those immediacy and immediate outcomes for people with MND that can translate into improved and extended quality of life. There's a lot of information in the survey and the report around advocacy priorities. Consistently, I hear the big issue for the community as a whole is the funding discrepancy between the NDIS and aged care. The aged care reforms coming in from 1 November this year will see a slight bump in aged care funding, but not even close to enough. There's also a lot of work in Canberra around the NDIS, and I think I'm cautious around making sure that we don't lose anything in the NDIS. Obviously, we've seen Mark Butler's announcement around children with autism announced as a fait accompli before he's even stitched up the deal with the states. It'd be interesting to see how that one goes while he's also trying to land the deal around foundational supports. But I do know that the next area, or one of the next areas that they're looking at, is SIL and SDA funding, and we'll make sure we're front and centre, making sure that people with MND don't lose out as part of the budget pressure that's on the NDIS. The government in the last term commissioned a report around the Therapeutic Goods Administration and how we approve medicines. To date, they haven't yet implemented many of the recommendations, so we'll be working with them to push for prioritisation around the recommendations that make a difference. It's about expanding compassionate access programs and bringing forth bridging funding so that people and pharmaceutical companies can be supported to make medicines more available while the regulatory process is going through, and also allowing more people to participate in clinical trials. There's also some really good information in the report that will feed into our advocacy priorities around supporting gene carriers, but also carers. Obviously, the impact on carers is significant, and we'll be looking at what we can do with the federal government to expand the carer support funding and programs, particularly for specialists or special groups of people such as those with MND. I think the other area that's abundantly clear needs a lot more funding is care, helping people. You know, funding programs for state associations and for clinics is well and truly prioritised in the report, and something that we'll be picking up with our state and territory associations. There's three areas.
Claire, I think your time is
my time is
lingering.
Up. Excellent. Well,
Final point.
Final point is reach out to anyone at MND Australia and the state and territory associations to be involved in anything, and we really appreciate your views.
Thanks, Claire. I'm tough with time.
It's a good thing.
Okay, Kate, can I hand over to you to talk on behalf of the state MND associations, and then we'll go to Min.
Yep, sure. Thank you. It's a really important piece of work that has been done here in collaboration with MND Australia, FIGHT and the state associations. I think it's really important to note that the equipment, education and support from the state associations has a really high impact on improving quality of life for people living with MND, and that's something we need to continue to focus on. Access to home modification funding obviously is a key facilitator of quality of life. There is very little access to funding for people using aged care services, and there are still delays and challenges for those on the NDIS, so that's something that we need to focus on. We have managed to establish with the NDIS the priority pathway, which seems to be working well for access and for requests for change, but the delays seem to occur once the person with MND needs a decision that's made outside that pathway, so by another team. So I guess that's the next level of advocacy to the NDIS we need to talk about. Obviously, funds from the NDIS to pay for equipment hire sees those eligible having better access. Those using aged care have funding caps, they have out-of-pocket costs. This group can access free equipment loans in some states through state associations, but need to pay in other states. And that's one of the big inequities is that even though aged care funding is lower, people are still expected to co-pay for everything pretty much. So the state association loan programs for equipment are extremely important to those who don't have NDIS support and to those who do. The survey highlights the importance of the state associations in educating allied health and medical professionals and the importance of access to specialist allied health professionals for people living with MND, and the important role of the state associations in addressing gaps in those services. It also very much highlights the importance of multidisciplinary care provided through clinics where they're available, but making sure that there are networks of people where people can't access a clinic. And it's really crucial that that is well coordinated. And obviously there needs to be more focus on supporting gene carriers as well. That's probably an area that some of the states haven't looked very hard at, but it's obviously an area that needs some focus. So thank you for your work, Lockie, Amy and team. It's a great piece of work and really important.
Excellent. Thank you, Kate. You were super good with your time. Min, can I hand over to you to talk on behalf of FightMND?
Yep. Okay, so I'm Min and I work for FightMND. So for those who aren't aware of who FightMND are, we're a charity that raises funds to invest in research to find treatments for MND, as well as trying to improve the care of those living with or affected by the disease. And as the funding that mostly invests in research, the survey outcomes have been really useful in informing some of the work that we currently do and providing insights into areas where we can look into improving. And there's just so much. So I'm just going to touch on a couple of points. So the first, I guess, is around the issue of inequitable access in care for those living in regional, rural, and remote communities and those that don't have access to the NDIS. And obviously, as well, trying to support families and carers. So these areas are issues that we try to support through our Care Support Grant program that we provide to organisations that support and provide care for people living with MND. And we do try to prioritise applications that address these issues. I think our funding, the funding we provide for equipment and services somewhat addresses these issues around inequity of access. And we also fund research projects that look at health gaps in Australia that might inform future policy or advocacy work. However, I also recognise that there is a lot more to do in looking after carers, and that's something I'd like to address in our next grant round and looking at implementing more. Second is around access to knowledgeable healthcare professionals. So at FIGHT, we've invested in the development of MND guidelines, which is currently led by Professor Zach Munn at the Uni of Adelaide. And the guidelines, ideally down the track, will provide health professionals, those who are familiar with MND as well as those who are not, about what is best practice and provide recommendations around patient care. So hopefully that will address some of the issues to health professional knowledge. The guideline project will also address hopefully address the types of health professionals that are required in a multidisciplinary care team, and this may improve access to counselling and palliative care down the track. That being said, I think issues around the lack of healthcare professionals in regional, rural, remote communities is not just an MND issue, it's a wider, more systemic problem. And I see opportunities to partner with other neurological disease organisations, especially in the research and education space, to try to help this, to try to address this problem in the longer term. The third is communication of research outcomes as well as research opportunities. And I think at FIGHT, we recognise that talking about research is really important, and we do a good job about talking about the research that we're currently funding. We do a less good job at talking about the outcomes of the research. So this is something that we have taken steps to start communicating on and trying to communicate that in a way that's understandable by a range of different audiences. So watch this space. And then in terms of research opportunities, MND Australia has a page on current clinical trials available in Australia. However, I think having a platform that has information not just around clinical trials, but also other types of research opportunities and maybe even surveys is something that is necessary and is something that FightMND will need to collaborate with organisations like MND Australia as well as researchers in the space to develop and ensure that it's regularly updated and communicated with to our lived experience community. And lastly, we will obviously be continuing to support research in the drug discovery and clinical trial space and finding the cause of the disease. That's our bread and butter, and we're not going to stop that. And while we have funded projects where genetic carriers are included in trials, it isn't something that we have prioritized in the past. We do note that there is an international push to promote research with gene carriers to prevent or delay the onset of disease. And in our 2024 Research Roundtable, one of the strategic focus areas was to develop a global approach to studying the asymptomatic disease, and it's something that we will be looking at implementing in our CURE program in due course. So I guess I'll just echo Claire and Kate and say thank you to Amy and Lachlan for developing the survey. And Julie, I'll just throw over to you to ask any questions.
Yep, wonderful. Thank you, Claire, Kate, and Min. I think that gives a good overview of each organisation's response to the survey and the sorts of things that we'll be looking at. We have a couple of questions already in the Q&A and some points here to cross to. So if you do have a question, feel free to type it into the Q&A box on your screen now. But the first question I wanted to cross to was probably one for you, Lockie. Just some questions around the data presented for equipment and home modifications. And so I know in the full report that data is separated into talking about equipment and home modifications separately. But there was a query as to whether we had any insights as to the differences in access per state. So was the experience of accessing equipment and home mods different for people depending on what state they lived in, or was it more whether they were regional or metropolitan?
Thanks, Julie. So the first one is that home modifications and equipment are separately addressed in the report. They have, though the order and severity of the drivers were largely similar, though of course finding qualified tradespeople is only relevant to home modifications. Regarding the differences by state, they were not significant when you accounted for difference by regionality, and not significant enough that they made it into the report, though the data is available.
Okay, thanks, Lockie. Did anyone else want to comment on that before I move to the next point? No? Okay, good. There was a comment asking about, or I guess drawing our attention as well to the fact that bereavement support for carers after their loved one has died. I guess there was someone in the chat reinforcing, I think, the importance of that. So does anyone have any comments on that?
Kate, I think you
Yeah,
do.
yep.
Yeah.
Yes, bereavement support is incredibly important. And I know that in the past, carers have felt like all the supports that they've had while their person with MND was alive sort of fall away as soon as the person dies. The states have done various projects around bereavement support. In Victoria, we've now have a counselling service that's around grief and bereavement that happens during the journey, but we also have a bereaved carers program that we are looking at as well. So it is an important area, often not one that is funded by any government body, so ones that we mission fund.
Can I add something else as well? So Professor Samar at the Parent Institute in WA, she's doing a research project looking at the experiences of carers who have a loved one who has passed away from VAD. So Mia, if you would like to be put in touch with Samar, I'm happy to make an introduction. Just let me know.
Thank you, Min and Kate. Okay. just that there is a comment in the chat as well that MND Victoria's equipment pool was amazing. When we needed equipment that MND Victoria were unable to supply, there was a shortage in equipment. So yeah, these are the sorts of challenges that people face.
That's
Yeah.
often an issue, Joy, is that by the time you order and wait for a new piece of equipment, that can be weeks to months, and the person's needs may well have changed. It's why the associations have set up their loan libraries, but of course we can't have every single different piece of equipment available all the time, but it's why the loan libraries work so well.
Thank you, Kate. There was a question about genetic testing, and a comment that, you know, someone living with MND reporting that they often hear on social media people with MND asking how they can get genetically tested. And, you know, the question was, I would have thought that this was automatic. So, you know, does anyone want to comment on the issue or the problem of genetic testing in Australia and the challenges that people face there?
Interesting, Julie. It should be automatic, shouldn't it, for people who want genetic testing, and for their families, of course, if they find out they're carrying a gene. In terms of government support, genetic testing is rebatable under Medicare, under the MBS. Genetic counselling is not. So sometimes there's a financial barrier. There's also a difference of services depending on the clinic that you go to, and we have a sort of a health equity issue in the country, that not all clinics are the same and not all people who go to each clinic receive the same sort of supports. I think the other one is there's a global but Australia-wide shortage of genetic counsellors to help people interpret their genetic testing. So there's a lot of work to be done to improve access to genetic testing for those who want it.
And the genetic counselling that sits around that is so important. Having a genetic test in isolation of that support can be really confronting and dangerous. Yeah.
Yep. Thank you, Kate and Claire. Okay, we have a question. You know, what's MND Australia's role in advocacy? What is this about?
Fair enough. So we, by way of structure, are a membership organisation. Our state and territory associations are our members. And to be honest, they're our intellectual depth. They give us the views and the understanding of what's happening on the ground. We also have the lived experience network so that people with MND can give us their views together. We're a very small peak body, and so we operate essentially to try and affect policy change and influence funding programs from the federal government. We have a small team of about 10 FTEs, myself and one dedicated policy manager. The way we work is we listen to the problems on the ground, we work out where that fits in, what the government's doing, whether it's a federal government, a state government, or even a local government service, and then work on a twin track approach where we try and get political support from the elected politicians, but also work with the policymakers, the public servants, so that they understand what's needed, they can shape their programs, and hopefully they're briefing up positively about what we're trying to push. There's sort of two ways of thinking about it. There's the proactive agenda, what we're hearing and what we want the federal government particularly to do. And then there's the reactive advocacy. There's a lot of consultation on most of the government's initiatives. And so we're part of providing submissions and providing advice to government on how the initiative will be implemented, and trying to make sure it's implemented in the best way for people with MND.
Thanks, Claire. Did anyone want to add anything to that? No? Okay. Just crossing back to the topic of genetics, Dr. Menon has made a comment in the chat that GPs and specialists can refer people to local genetic services in each local health district. So that's, you certainly can speak to your treating medical team about that topic if you have questions. There is a question, are there webinars about the causes of MND? How
That
can people learn more about the actual disease?
Yeah, that's really interesting. There's a lot of information online, including one, Julie, which you, I think, have recorded and put online. The cause of MND is incredibly complex and we just don't know. I think collectively we all know that we need better data, better linked up data and integrated data sets so that we can ask data scientists and researchers to start looking at and inferring the trends to direct research to look at what causes it. When you talk to people who know far more about it than I, they say it's going to be a combination of genomics, cell biology, social and environmental factors. And it could even end up being that there's multiple diseases. There's a lot of work globally that's going on, both in improving data infrastructure and analysis, and also, really good science looking at what causes the disease. But Julie, Kate, Min, I don't know if you have anything more to add to that, but it's really, I think it's one of the reasons why we attract such good researchers, because there's such big questions about this disease. We unfortunately know so little.
I guess by MND, we do have webinars around the science of MND. They are targeted to a very scientific audience, though. I guess one thing I can also try to plug, I guess, is PACTELS and the CARE Forum that's happening in September. So those would have a lot of information. If those would have information around the cause of disease, access to clinical trials, etc., etc. It is in Melbourne. If you can't travel down to Melbourne, there are online sessions which I think are free for people living with or affected by MND to attend.
Claire, Kate, did you want to add anything there about the potential online webinars or things that are offered through the state associations there to learn more about the disease?
Yeah, thanks, Julie. We do have webinars for people who are, or information sessions, both live and webinars for people who are newly diagnosed, which covers sort of what we know about MND, but also what services and supports are potentially available. The state associations have collaborated on also an allied health professionals education series, following through a number of topics to try and upskill our allied health professionals as well. And there are other online education programs as well through the states for people living with MND and for carers.
Thanks, Kate. And I think our last question for today, because I'm conscious of the time, or it's a consideration, I think. There's a query, will we ever reach a saturation point with research? And how do we find that balance between funds directed to research versus funds directed to care? Does anyone want to comment on that? It's a really tricky topic and subject.
It's one that certainly the MND Australia board and the states and I talk about a lot. And I think it's worth thinking about in terms of what we hear from people with MND. When you talk to people with MND, they really, really want a cure, which makes perfect sense. And there's really good research going into finding a cure. When you ask them what makes the biggest difference to their lives now, they tell you that it's the services and support provided by the states and at clinics to improve and extend quality of life. And when you talk to them a bit more and talk through, wouldn't it be great if we knew what caused the disease and we could prevent it? Everyone agrees that that's the ultimate goal. So I think it's worth thinking about cause, care, cure, and thinking about the balance of how we do that. I don't have a weighting or a metrics. It's certainly one that we're all looking at. But I think globally, there's a lot of really good work going into finding a cure. And certainly, we probably have the world's best researchers here in Australia. But you're absolutely right. Looking at how you improve and extend quality of life until we have a cure and ultimately can prevent it. We've done it for other diseases. Think COVID, AIDS, MS. These are no longer terminal conditions. If we work together and we really do unite and collaborate and share our limited resources, we can make much more progress with this disease.
Min, comments?
I guess from FightMND's view, research, I know that we have invested a lot of money in trying to find a cure for a disease over the years. That being said, MND is such a complicated disease. It's likely there's no one single cause. There's so many different types of genetic mutations that may be involved in motor neuron disease. So I think I don't know when the research will reach a saturation point. However, we recognize that we don't know that. So we are at the moment trying to direct some funds into trying to support people living with the disease, as well as research into improving the care of people living with the disease. I can't tell you the split, it changes. But that's all I can say.
We need to do all three, don't we? And
Yeah.
we need to keep supporting really good researchers, to keep supporting states and clinics and service provision, and to work together to improve the data so that we can develop the evidence we need across the whole care continuum. So yeah, I think it's about cause, care, cure, and making sure we're appropriately and to the best of our ability doing everything we can on all three fronts.
Wonderful. Okay, so thanks, Claire and Min. And we're now on 12:01. We're 1 minute over, so I will need to bring an end to the session. I hope you all enjoyed what was presented today, and a big thanks to all our presenters for coming online, and thank you to all of you for joining us as well. If you have any questions, feel free to reach out or check out our website where you can see the full report, as well as a 2-page infographic. Thank you, everybody.
Thanks very much.
Bye-bye.
Thank you.